My lady, good morning. May I please call Professor Simon Ball?
Just repeat after me, Professor. I do solemnly, sincerely and truly.
I do solemnly, sincerely and truly.
Declare and affirm.
Declare and affirm.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth, the whole truth, and nothing but the truth.
Shall be the truth, the whole truth, and nothing but the truth.
Thank you.
Professor, good morning. You've produced a statement for us, and that is our reference INQ 304777597. Professor, it's correct that you were the Chief Medical Officer for the University Hospitals Birmingham NHS Foundation Trust from January 2019 until January 2024, is that right?
That's correct.
The questions I'm going to ask you today are focused on the Queen Elizabeth Hospital specifically, and that is a hospital within that trust, is that right?
That's correct.
Can you paint a picture for us of the hospital estate and how that may have benefited you or otherwise during the pandemic?
Yes, so the Queen Elizabeth Hospital, which I'll refer to as the QE, if I may, is largely supported by a modern estate, so a large hospital building with some historic buildings alongside it, that was opened in 2011, so a largely modern estate with around 46%, I think, single side rooms, so with en suites, and then in most of the rest of the wards, then 4-bedded bays with again bathrooms associated with each 4-bedded bay. So no open wards as such. In addition to that, the hospital was designed with 100-bedded capacity for 100 ICU beds, of which 67 were funded. So very, very large capacity for intensive care.
I want to start with that topic of bed occupancy and capacity. On the 17th of March 2020, the NHS England discharge policy was issued. At that point, it's right, isn't it, that the hospital had over 1,000 general and acute beds with approximately 960 occupied?
Yes, at that stage, yes.
And of those 67 ICU beds you've just referred to, approximately 40 were occupied.
By that stage, that's correct.
So would it be accurate to say that at that date there was some available capacity?
Yes, because we actually recognised the fact that the pandemic was coming in the year leading up to that. There was approximately 99% bed occupancy across the trust, and similarly in the ICU.
So is it right to say that you took action before that policy? That's
correct.
And did you take any further action once that policy had been issued to increase or to discharge patients from those beds?
So the NHS England policy was actioned on the 17th. It was apparent to the senior clinical leadership that the pandemic was going to significantly affect the country. So we continued on the work that was already had been going on over the previous 2 weeks to reduce bed occupancy by expediting discharge, and then from that point forward we stopped almost all elective admissions other than those that were urgent.
And is it right that you expanded the ICU bed capacity from the 67 you've just referred to 126 by April 2020?
That's correct, yeah.
Can you give us an idea as to how you went about achieving that at a practical level?
So I think the first thing that I should say is that much of this was delivered by senior responsible clinicians that we appointed at a hospital level and who were leading the ICU response as well. So we changed the way that we'd organised our hospital and senior clinical management to be very much more site-based than across the hospitals. And they played a major role in changing the way that we organised ourselves. To give you a feel, to support 67 ICU beds, you probably need around 450 nurses to provide one-to-one care. So, and when we topped out then the following January, we're talking about providing the equivalent of 1,000 ICU nurses. So.
Sorry, I just want to stop you there for one moment. So we will come on to look at the expansion of capacity in January, when it in fact expanded further, didn't it, in 2021? I think you've said in your statement that in April 2020, the expansion would have required an additional 205 doctors and 429 nurses.
Yes,
Does that sound right?
That sounds right. So the equivalent, getting on for 1,000 in total to provide that kind of level of support. And so that meant bringing in staff who were not currently working on ICU. So that meant staff nurses that were working on the wards. We had support from across what is now the ICS, then the system, so other hospitals within the Birmingham and Solihull system, and had staff members redeployed. And indeed, we had other healthcare professionals. So we had some senior surgeons providing the one-to-one care to patients, all supervised by then at a level of pods of four beds, senior intensive care trained nurses. So it was a matter of expansion and reorganisation of the way that we did things. And I'll perhaps then come on to not only delivering that one-to-one care with high levels of supervision, with high levels of early retraining, and of course provision of clear protocols around COVID-19. But in addition to providing that one-to-one care that was closely supervised, we also set up teams to provide particular functions, so such as inserting lines or forming tracheostomies, or indeed proning. So that's where you ventilate patients on their front. So a whole team dedicated to simply supporting turning the patient, which if they are ventilated is a major undertaking. So a complete reorganisation in the way that the intensive care was delivered and supported.
And is it right that you created a reservist workforce, essentially the individuals you've referred to who were trained to support ICU when it was required?
Yes, it came to be known as the reservist workforce later in the year, but those that we had had experience, had been trained, became known as the reservist workforce, because then when it came to redeployment, we understood who had actually had experience, who had been trained, and who had been developed in a way to support the ICU.
And you've referred to some one-to-one care being provided by those that were deployed or redeployed. Is it correct that there was also a stretching of patient ratios during both waves of the pandemic, nurse to patient ratios?
So that is not strictly true. I think it's actually the skill mix that changed rather than the ratios. So there was one-to-one nursing on ITU, but the skill mix changed. So we would usually have an intensive care trained nurse per patient. They weren't always intensive care trained nurses, but they were overseen at a kind of pod level of four by at least one intensive care trained nurse.
In December 2020, the CQC carried out an unannounced inspection of the hospital, and one area of improvement that they identified was the staffing levels to ensure that there was an adequate number and skill mix on each shift. Around that time, there was, you said, a very high number of COVID-19 patients in the hospital, and shortly following that, in January 2021, ICU bed capacity again increased from the 126 to 142. So in light of that, was it possible to achieve the adequate number of staff with the right skill mix on each shift during that period?
So it was possible to achieve the right number of staff. The skill mix is as I've said, is a different matter. You would usually expect a one-to-one intensive care nurses. So on intensive care, and I'll come back to wards if I may in a moment, but on intensive care, absolutely we sustained a one-to-one ratios, but not always of intensive care trained staff, but overseen by layers of supervision, both in pods of 4 at section levels of maybe 5 or more pods and what have you. So that's really what we are talking about in terms of those ratios. In terms of the wards, indeed, there were challenges. And again, we were redeploying those nursing staff and indeed other allied health professionals into wards that had not had recent experience of acute medical inpatient care and what have you. And again, that required significant amounts of training, close support and supervision across groups of wards and what have you. So I think the CQC inspection was indeed important in re-emphasising how we needed to keep on addressing supporting that particular differences in skill mix. So that particularly, for example, if you had overnight two or three of the core staff on the ward, plus then others, then you'd want, and perhaps those core members of staff went off sick, then that needed an urgent response from the site team, or the way that we organised ourselves was across floors, because there are 7 floors at the QE.
And did you always have an adequate number of staff, senior staff, to provide that supervision and support?
There was adequate provision of senior staff to provide that support. That's correct.
And you have said in your statement that the lack of workforce capacity did lead to deficiencies in patient care and delays in transfers of patients from wards. Is that right?
So that's correct. So the skill mix impact is around the efficiency in which care was delivered. So it may be in transfers of care, it may be that drug rounds were slower and less efficient, and that kind of thing is are the areas that inevitably impacted upon by having a less experienced skill mix.
Staying with the topic of transfers, you've said in your statement that due to the size of the hospital, it's more common for the hospital to receive transfers in. And in fact, you received 363 transfers in during the pandemic. Is that right?
That's the intensive care. I think you're referring to the intensive care transfers. So most of the QE's intensive care capacity meant that almost all of the transfers were in, and they were mostly in from other hospitals within Birmingham and Solihull. And that reflects the fact that there was such a high incidence of COVID-19 requiring ventilation across Birmingham and Solihull.
There were some transfers out of the hospital, though, wasn't there? 43 of the 160 transfers out occurred during a 28-day period at the end of January 2021. Again, were they ICU transfers?
So that I think the paragraph you're referring to are ICU transfers coordinated by the regional and national coordination teams, and those were hugely appreciated, obviously, by the teams, not just the sheer numbers, but just feeling that they were being supported by across the nation, actually, and an understanding of quite how intense the requirements for intensive care in the hospital were.
What were the reasons for such a high number of transfers in that short period of time?
So in January 2021, across the trust, and we were operating as a single trust in terms of provision of ICU care in particular, we peaked at more than 100 COVID-19 admissions in a day. So there were huge demands with regards to that peak of COVID-19 presentations requiring hospitalisation, and of course a proportion of them requiring ventilation on intensive care. So that was the reason. And I think in our exhibits you can see this peak in ITU bed numbers around the 21st, I think, of January or so.
You've said in your statement that during wave 2, so around this time, ICU was operating at 206% capacity, but the ICU only came close to crossing the limit at which it would have been necessary to review criteria for ICU admission. We will come on to discuss the criteria, but can we assume from that that the hospital did not cross the limit?
You can, and it's difficult to know what that number actually is, but when you have 142 ventilated patients on a single floor ICU, you are really looking for at the limits of capacity. So, but I think it's probably fair to say that if I'd have asked the teams when we first started, could we have ventilated 142 patients, they would have had their doubts. So it's difficult to know exactly where that limit was, but we didn't reach it.
You've said in your statement, in short, maintaining the basis for admission to ICU, benefiting the patient population and not altering the basis for admission in the face of the pandemic, nevertheless came at significant, often personal cost. Is that right?
I think that's true, and I think that there is no doubt that operating at the level of intensity with even for experienced ITU nurses, dealing with such an influx of very acutely sick patients who often spent many, many weeks on intensive care to recover. As you know, a very high mortality, particularly in that first wave, came at significant personal cost in terms of individuals' well-being. I think that's entirely true.
And I think you've said in your statement that there was also an impact on the staff that were treating patients outside of ICU as well.
I think it's easy to focus on ICU. I think we need to remember that the majority of patients were cared for, on the wards. And again, we were dealing with, even for staff members who were used to dealing in highly intense environments, in populations with who were often very sick. This was a step up again. And then we were bringing in staff from across the hospital who weren't used to working in acute medical wards at that level of intensity, dealing with patients who were dying, and who were quite so acutely sick. So I think it's really important that that's acknowledged as well.
And can you provide some examples of how the hospital or the trust more widely supported staff not only working in ICU but also on those wards as well?
Yes, I mean, I think that, the important thing to say is that, our approach was multifactorial. It involved local support and a significant amount of local support from their local managers, but then broader approaches to maintaining and sustaining health and well-being, both using kind of national approaches, training staff as psychological first aiders, and then kind of practical things, just in terms of provision of food and provision of drinks and the like, particularly at those peaks when we were actually separating and ensuring that members of staff weren't meeting, that is to say, they were meeting infection prevention control guidelines. And I think that was, if I may just briefly dwell on that, I think that was particularly tough for staff because in those, in the setting where you're dealing with something completely new and highly stressful, then you normalise that by discussing those matters again with your colleagues, understanding that you are not the only person who's going through that. So in addition to this, the challenges around maintaining good infection prevention and control almost took out those internal support networks, so we had to recreate those in many ways.
on a slightly different topic, but around capacity, did the hospital or trust discuss use of the Birmingham Nightingale Hospital facilities to transfer patients in order to manage capacity?
So we did. So a team from the trust was responsible for standing up the Nightingale Hospital. We tried to keep that team small and separate from those delivering the rest of the response within the trust. Fortunately, we did not need to use the Nightingale Hospital, but it was supported by the trust.
Did it have any impact on the hospital's ability to care and treat patients by deploying staff members to the Nightingale that weren't then needed?
Yeah, I guess I've kind of anticipated that question in a way by saying that it was a small number of staff and we separated out that responsibility so there was no conflict at an individual level, which is often more difficult to manage than it is at a kind of organisational level.
Turning then to ICU admission, you've said that the criteria for admission to ICU at the hospital did not change from usual practice, and the senior ICU clinicians supported decision-making around admission. Is that correct?
That's true, yeah.
And how were those senior clinicians supported by the clinical support group and clinical ethics group that you've referred to in your statement?
So I think if I can expand on that a little bit. So the first thing to say is that we deployed very large numbers of senior clinicians onto the wards 24/7. That they were involved in both determining escalation or identifying patients who required escalation, but also having early discussions with patients around their prognosis and their preferences for escalation of treatment. So that's really important. We were conscious of the fact that those clinicians would be having many such discussions in the context of the pandemic at a very early stage of admission, because we knew patients were deteriorating quite rapidly. The clinical support group was set up to provide opportunity for clinicians making those decisions, particularly if they felt that the discussions were particularly difficult, to seek support. As it happens, that was an offshoot of the clinical ethics group, but was kept separate from the clinical ethics group. As it happens, most clinicians sought support from the other senior clinicians, including intensivist respiratory physicians, who were actually available across the floors within the Queen Elizabeth Hospital.
And did you develop or disseminate any local guidelines to support that decision making?
Yes. So a range of guidelines that were continuously updated and were supported by something called the Medical and Scientific Advisory Group that were responsible for reviewing all of the guidelines, ensuring that they were kept up to date, and publishing those and disseminating those.
Did you receive any feedback from staff as to how useful or otherwise they were?
I think that it was what was particularly appreciated was the microsite that we set up, which provided easy searchable access to all of the guidelines, and I think at its peak was accessed 23,000 times in a day. Now, I should say that we opened that microsite up not only within the trust but to the outside world, because we felt that we were a very big centre with a great deal of experience. We felt that actually we wanted to share our experience and what have you. And that microsite was accessed a total of 4 million times. So the feedback we've had was that the whole range of guidelines were really appreciated, but actually particularly the ease of access and the ease of discovery of the right guideline was.
Can you recall when the microsite was made available to staff firstly and then to the public?
I think it was in April of 2020.
2020.
Yeah. No, I think it was stood up pretty quickly because it became apparent that we needed to rapidly disseminate information, and email wasn't good, and you had to search. We need to have something that's really easily searchable, essentially.
And in your statement, you've referred to insights that were published during the pandemic. It's at paragraph 200. And one of those was in relation to the first wave of the pandemic on the impact from people from Asian communities was more likely to present with severe symptoms, but no difference in duration of symptoms, and they were more likely to be admitted to ICU. And then how that knowledge changed how you assessed severity in that population, including more close monitoring to identifying signs of deterioration and a lower threshold for ICU review. So did those insights, such as the one you've explained here, inform the ICU admission criteria and the guidelines that were developed?
I think not so much, ICU admission criteria, but overall approach to treatment of patients, I think, but around where your level of concern is and what have you. And I think, I think that paper was published, was based on data up to the end of April, and we'd already admitted 2,200 patients at that point. So we were constantly learning from the data as it came through. The QE in particular at the time benefited from an electronic healthcare record that had been developed in Birmingham over the previous 20 years, that we were able to adapt and collect new information, new forms of data, and at the same time also provide electronic clinical decision support based on those new insights. So creating bundles, investigation bundles or treatment bundles to ensure that people were getting absolutely the right treatment they were getting. So, I think the thing that struck us was that essentially young Asian men were presenting later than the rest of the population, but with really, quite serious disease. And part of that was internal, but it was also getting the message out externally across the population to not delay attending.
And you've said that you did not reach the point of having to review the criteria for ICU admission, but did you prepare for that eventuality?
So I think it was a debate that was going on nationally, and it was particularly in that first month when the Ferguson modelling had, if you extrapolated the Ferguson modelling unmodified, we were having to ventilate 500 patients across Birmingham and Solihull. Had that peak not been flattened, we would not have had enough ventilators to do that, let alone any of the other considerations around capacity. So I think it was a national debate or a national discussion rather than one particularly locally. I think understood by the senior leaders, but I think that you need to be careful at which point you kind of change. Unknown to yourself, change people's attitudes and what have you. So you're quite careful not to, and to emphasise that we will come to that and deal with it as and when it is necessary. Unfortunately, it wasn't, but it was a widespread discussion, obviously, in the context of the modelling.
By the modelling, Ferguson modelling, you mean the Imperial College Professor Neil Ferguson?
Sorry, yes, I do.
Right, no,
yeah.
I know, obviously, from all the evidence I've heard.
My apologies, yeah.
For those watching.
Thank you. Staying on the topic of ventilators, you have explained in your statement how the supply of ventilators was a concern, particularly as you received unsuitable machines from the central supply, but that had been rectified by January 2021. Was there any point that you ran out of ventilators?
No, there wasn't. And so what we're referring to with regards to the central supply was at the end of March of 2020 and what have you. And I can tell you, hours felt like days and days felt like weeks at the time. Clearly at the time, the effects of lockdown hadn't really kicked in. There were concerns with regards to the fact that we might, had the increase in requirements gone unmodified, but they didn't. And over a matter of days, then new extra supplies of ventilators were coming in. They're clearly needed across the nation, I think it was simply that the ventilators, the one batch of ventilators that we received, were really only suitable for transferring patients, not managing patients on intensive care. And I think that we included that because we felt it's the whole issue around precision of procurement, I think is a potential learning for this in terms of any future response.
We will come on to discuss some of the issues you set out in your statement around PPE and RPE procurement and the supply. Were there any processes in which you could provide feedback about the quality and suitability of the equipment that you did receive?
So we have an excellent director of procurement who I'm aware has provided evidence for a statement for Module 5. And that feedback really went back through the Director of Procurement, who had a role or had good lines of communication nationally, yes.
Before we come on to that, I just want to finish the topic of escalation of care. In regards to any patient presenting at the hospital, is it right that the care escalation decisions were made when the patient was admitted and would be recorded in a treatment escalation and limitation form?
That's correct, yes.
Can you briefly explain what that form is and how it's used?
Yes, and many people will now understand that as a respect form that others may have heard. At the time, that had initially been implemented historically in the electronic healthcare record as a treatment escalation and limitation form. And it's an opportunity to determine or to describe, I should say, the discussions that have gone on with the patient and around their preferences and around not only limitation but actually escalation. I think that's a really important point. So it may be not for escalation for ventilation, so invasive treatment by ventilation or other invasive treatments, maybe not for cardiopulmonary resuscitation, or for those things. And I think what we did see during the course of the pandemic, we were encouraging that every single admission should have that recorded, and we saw a significant increase in positive affirmation of for these interventions, not for these not for these escalations, and those are then reviewed on a daily basis. And you mentioned earlier some of our processes and protocols, and for example, one of the areas that we brought in very explicitly, although it was available in national guidance, was the importance of suspending non-resuscitation orders in certain settings that were associated with specific interventions, whereby one might that were easily reversible. So if you are taking someone to theatre or they're having an endoscopy, I'm a kidney specialist, so somebody undergoing dialysis who then loses their blood pressure, it's perfectly appropriate and reasonable to intervene at that point. If they've had a sudden abnormal arrhythmia in the setting of a general anaesthetic, it's very reasonable to intervene at that point, despite a non-resuscitation order. And that's discussed with the patients at the time, making the point that treatment limitation does not imply non-treatment and does not prevent sensible intervention in settings such as that.
And did staff receive training during the pandemic on when and how to complete those forms, or if there was any changes?
So we were so the answer is that this is part of standard practice. That's the first thing to say. The training really related to dealing with some of the specifics around timeliness of addressing those issues, and those specific questions that I've just alluded to that came up around ensuring that we were actually addressing all of the questions that members of that our patients may have brought up.
You've explained in your statement that there was a drop in discussions involving family members of approximately 25%. What, in your view, led to that drop? And also, again, did staff receive any training about how to communicate with family members in the circumstances of the pandemic?
So I think that so what you're referring to there is a paper that we published in Resuscitation that identified, that identified that 96% of patients were involved in that decision making. The numbers of the amount of family engagement, I think, simply reflected difficulty in. Usually, you've got family members coming in with patients with them, and that discussion is happening at the time. So I think that reflects then during those initial discussions, then difficulties in contacting and identifying family members and engaging in those discussions relatively early in the admission, because we were aware of the fact that patients were deteriorating quickly.
And did you observe any changes in the number of DNA CPRs?
So there was a small increase in the number of patients who were presenting from the community with DNA CPRs across their reporting period, which increased from around, I think, 4%. It depends on which population we looked at, between 4% to 8%. The total, I don't actually have the data to hand in terms of total DNA CPRs. What we saw was an increased utilisation of the treatment escalation and limitation form.
And what support was put in place and when for patients with learning disabilities, dementia, mental health concerns or communication difficulties if they couldn't be supported in decision making by their family or a carer?
So I think the first thing to say is that we went completely out of our way to identify those individuals and to maintain as standard a practice as we possibly could. So we would usually look for a mental capacity advocate and what have you. But at the end of the day, there would also ultimately there would be a best interest decision made by the clinicians caring for a patient, but not only in the event of having exhausted every opportunity for accessing next of kin advocates and what have you.
Moving on now to a different topic, infection prevention and control measures. The inquiry's heard a lot of evidence about the national IPC guidance. From your perspective at a hospital level, was there parts of the guidance at national level that was more helpful for implementation at that level?
More helpful. I mean, I think. I think it was very wide-ranging. It was at the end of the day, it's always helpful because trying to synthesize the evidence yourselves is impossible and what have you. I think that there was a lot of it, and it came through frequently. If you ask the teams, they would probably say it felt like it kind of came through on a Friday evening, but I think that's probably perception bias rather than actuality, if I'm honest. The fact is that we had a team stood up 7 days a week through through most of the areas where the times where there was a lot of demand for them to change.
But the content, Professor? The
content. I think from our perspective, it was helpful. I'm trying to think of a specific example that you may be thinking of where it might not have been helpful. So I think the volume was the thing of actually turning that into a simple message. And I think we gave some examples of infographics that we used to actually say take relatively complex advice into a simple message that is to be delivered by the individual. Because at the end of the day, IPC is around a lot of it is around individual behaviour as much as anything else, if that makes sense.
Can you give an example of a part of the evidence that you, the guidance that you did translate into infographics in order to make that message simple to understand and then pass? Yeah,
I think I think we've given a few examples there. One of which is how to use face masks. In the early days, of course, there was a proliferation of different face masks being used and what have you. Again, infographics, but also working with individuals around the importance of maintaining your face mask wherever you were in the hospital. I think I alluded to it earlier. There was an understandable desire to be able to share your experience with other members of staff and what have you, but actually focusing on limiting your exposure to your colleagues, particularly in those early months before we were able to be screening not only patients but members of staff for the presence of COVID-19 virus.
And you've described fit testing for staff as being slow in your statement, and that there was a period in which frontline staff had to be prioritised.
Yeah.
How long did that persist for, and were you able to expand the team to meet demand?
So there are two elements to that. One of which is we stood up a fit testing team that was dedicated to that, but there were also consumables that were required in order to be able to fit test individuals. Then combined with that, something else that we allude to is then consistency of supply. So your fit testing is only applies to the make and model of the mask that you've been tested on. And clearly when supplies were stretched and what have you, we might be receiving supplies of a different form of FFP3 mask. So that's, again, if at an organisational level and therefore at an individual level you can maintain that consistency, that would have improved the efficiency of what we're undertaking.
And how did you mitigate some of those supply issues around the PPE or RP that was received?
So, the procurement team took pride in their ability and working with local providers, but also access to a very large number, ultimately, of hoods, which are suitable across, for a wide range of individuals, whereas the masks are more dependent upon A, fit testing, and B, whether you can actually get a mask to fit you.
And can you briefly explain what the impact was on staff of some of these PPE supply issues?
Yeah, I think, we think about this in terms of were they protected or not, but actually I think that the most important thing is that members of staff felt that they were being given the best level of protection that was available. And so that's it's a subtly different point that I'm making. We would never have put people into a position where they weren't protected, but they wanted to feel that they were getting good levels of supply and certainty of supply rather than thinking what happens if this supply doesn't come through a day from now or 2 days from now. So it was an additional uncertainty on top of everything else everybody was having to deal with, was the source of concern. Hopefully that answers your...
Did staff feel like they were receiving the best level of protection from the PPE that you could supply them?
I think they felt that they were using the best PPE that was available, but they would have been aware of at times frustrations around ultimately equipment that had to be discarded, for example, or that they felt that really turned out to ended up with feedback, hence to be discarded. So masks masks where the kind of ear connectors keep falling off, or simple plastic gowns where the ties tended to break. You just don't want that. And at the end of the day, we received feedback. We took those out of circulation to ensure that our staff were protected. But it's a really important part of the psychology of supporting your staff through challenging times.
In terms of COVID-19 testing, did you have any problems accessing a sufficient number of COVID-19 tests for staff during the early stages of the pandemic, and did it improve?
So, the answer is yes. But I think if I could add, I think the response, the speed at which testing was developed and ultimately implemented was pretty impressive. In fact, of course, yes, in the first month or two after the pandemic, yes, it led to particular challenges around getting staff, identifying that staff were positive or negative, and then planning with regards to deploying staff and what have you. But in truth, knowing about how long it usually takes to tests to come into being, then it was pretty impressive actually how quickly it was achieved.
Moving on to nosocomial transmission, you've set out in your statement that the hospital experienced 73 COVID-19 outbreaks from the 1st of September 2020 to June 2022, and that's defined as 2 or more cases linked in place and time. In your investigation of those experiences, were you able to establish any significant repeat contributory factors to the rates of transmission?
So, I think the first thing to say is that before the availability of regular testing of staff and of patients, then that was clearly a significant contributory factor. I think that if I may, I'd also say that the rates at the QE were really relatively low, and I think benefited from the estate that I've just referred to. It was, the estate was very different in our other hospitals, some of which are in kind of late 19th, early 20th century estate, much more crowded beds that are closer together than the very wide spaced out beds on the wards at the QE, corridors that you can't fit 2 beds down, which you can at the QE. So I think that comes back to the estate question.
Moving on to vaccination as a condition of deployment, you have very helpfully set out in your statement all of the actions that the hospital and the trust took in order to prepare for that being introduced. You've described it as time-consuming and difficult due to access to data being variable. What was the impact on staff of the prospect of this being introduced?
So there's the impact on the staff who were kind of directly affected, I think it's fair to say, and then there's the impact on the staff who had been vaccinated, because they had colleagues who were being affected who had stood by them during the course of the pandemic, and I think that was clearly widespread concern. I think that what we did was to try and work with those members of staff to provide them with as much information as possible, both with regards to addressing any concerns with regards to vaccination, but also being, supporting them if they'd chosen not to be vaccinated as to actually what the outcome would be, how one could adapt things, etc. I think in that we were hugely supported by our staff side representatives who were, very, very helpful in that regard.
What would the impact have been if you had lost those staff members due to the policy being introduced?
I'm not sure that we've actually quantified that, if I'm honest, because obviously that policy that was then changed. I think it would have been significant, but I think it would have been even more significant in terms of the concerns of their close colleagues and their perception of the fairness of their contribution to the COVID pandemic response having been acknowledged.
Briefly on the topic of visiting guidance, the inquiry's had a lot of evidence about visiting guidance. So I just want to ask you about two discrete topics in this regard. The first is in regard to what local guidance and discretion was in place during the pandemic to allow for visitors to attend in specific circumstances and whether that changed.
So the local guidance around discretion was effectively in a number of areas, and one of which was end of life, one of which was, and the other predominant one was those with difficulty communicating, so patients with dementia, with learning disability, autistic spectrum disorder, and then particularly as for those with prolonged admissions, those whose mental health was really significantly suffering from it in the context of a prolonged admission. So those are the opportunities for, or the guidelines around particular, the appropriate room for discretion.
And again, in your statement, you very helpfully set out in detail the role of the ICU family liaison team that the hospital introduced. Can you briefly tell us what that team did and whether it was successful?
It appeared, I'll answer the last question first, it appeared to be very successful. The ICU liaison team, so it became clear that, that a lot of the role of an ICU nurse, or a part of the role of an ICU nurse, is talking to family and liaising with family. It's an incredibly stressful to have a family member on ICU. That was simply not possible in the settings of levels of protection from aerosol generating procedures. So we set up a family liaison team, largely, not entirely, but largely staffed by medical students, overseen by retired intensivists, led by an intensive care doctor, who every day phoned a family member to give them an update on the patient, on the patient on ITU, using a kind of summary that was in the electronic healthcare record, so that they were able to receive that on a day-by-day basis. There was a lot of positive feedback, both from family, but also from the intensive care nurses, who felt that they weren't delivering the level of care that they would usually hope to by not being able to speak to or talk to the family. So that was a good thing. If I have any regrets, it may be that perhaps, could we have extended that even further, I think.
When you say extend it further, do you mean outside of ICU?
Outside of ICU, I mean, yeah.
Moving on to the topic of long COVID, you have said in your statement that 36 staff members have long COVID, but it's had a minimal impact on overall staffing levels. When did you start collecting data on staff members suffering from long COVID?
I actually don't have that to hand. So I happily provide that.
Not a problem. Are you able to help us with when the Staff Network Forum and the Trust-wide long COVID leave guidelines were introduced?
So across middle 2021 and then onwards from there. So that in 2020, obviously there was a change with regards to sick leave guidance in 2022 with regards to long COVID.
Yes, national guidance to support managers and leaders with staff suffering from long COVID was published in February 2022. Would it have been helpful to have had that guidance any earlier?
February 2020, I think a number of months earlier, but we were in the middle of the, if we think about the peaks of the pandemic and what have you, really latter part of 2021 might have been useful. I think it's, you know, I'm just thinking about our ability to respond to the guidance and what have you would really have come along in mid 2021 onwards.
Thank you. Professor, you've provided a number of recommendations and lessons learned at the end of your statement, and I would encourage anybody interested to look at those in detail. But are there any that you wish to particularly bring to your ladyship's attention? It's 253 to 262 of your statement, if that assists.
You will have heard, I think, around, or you will hear around ICU capacity across the country. And it's not simply and how that compares to European comparators, for example, but also there is significant within nation variation in ICU capacity, which is probably important to consider. I'm conscious that of time. I think that those are probably, and then I think broadly speaking, the importance of the built environment in our ability to respond. We've talked about the Queen Elizabeth Hospital. The learning in many ways is the compare and contrast to a modern built hospital to older infrastructure that we saw across the trust. I think that's probably and I think we benefited from the ability to adapt our electronic healthcare record in ways that generated useful data that contributed to the national understanding of COVID-19, but also that improved the care that we were able to deliver patients by delivering consistent advice to the clinicians caring for patients. I'll probably stop there. I can see the clock across there.
I'm grateful, my lady. Those are my questions.
Thank you, Ms. Hands. Ms. Jones, Jessica Jones, behind the pillar at the back. Nope. That's better.
Yes, thank you. Professor Ball, I asked questions on behalf of Care Rights UK, John's Campaign and the Patients Association, all of which are organisations who represent patients and those receiving health and social care along with their loved ones. The questions that I want to ask you today are about the visiting guidance. You've already said this morning that there were certain categories in which NHS guidance allowed for local discretion to permit continued visits. So for some patients with dementia, communication difficulties, learning disability, autism, or whose mental health was deteriorating. Can I ask on a practical level, how were those patients identified and how were continued visits for them supported by the hospital?
Yeah, so the level at which discretion was exercised was at a ward level and a ward leadership level. But I think in our evidence, we also mention a very significant increase in the capacity of the vulnerabilities team, and we'd identified actually before the pandemic, the need to develop a team that were dedicated to supporting, not delivering care, but to supporting wards to ensure that reasonable adjustments were made in various settings. So that team more than quadrupled in size across the pandemic, and they were able to support each of the ward, every ward, around patients with dementia, with learning disability, with autistic spectrum disorder. So I think as time went on and as that team grew in size, then again, they were able to act as combined advocates, as it were, in addition to the family and loved ones.
And visiting was generally restricted, your evidence says, to one visitor. Was any distinction made between those who were there as visitors per se and those who might have been there as familiar carers providing health care to people with those conditions?
I don't think there was. I think it was on infection prevention control grounds. It was kept to a single visitor.
Again, in terms of how the exceptions worked in practice, was it your view that they did work? And was there any opportunity for you to feed back to NHS England about how guidance might be broadened or changed to be more effective?
So I think that on the whole, the feedback that we got was often positive, but sometimes, but sometimes there were concerns brought forward, but those concerns tended to be addressed, as it were. So rather than as a source of data, they were treated as an opportunity to try and address with the individuals, with the family members, usually family members, their specific concerns and what have you. So I think that's important. I think it was an extreme, as you appreciate, it was an extremely challenging time trying to balance infection prevention and control and what we knew about the importance of visiting with regards to individuals' mental health and indeed their physical recovery. We all will be aware, you will particularly be aware of the importance in terms of mobilisation, in terms of nutrition, etc., the role that family take. It's an incredibly difficult balance to get right, if I'm honest. And I think the point that organisations like yours make is incredibly valuable because it's easy to become focused on the numbers, as it were. So, increasing numbers of infection, what have you. So combining quantitative and qualitative information is a challenge, but it's really important that qualitative information is brought forward.
Thank you. Can I just to clarify on that, you've given a helpful answer there about what the hospital did in those circumstances where it went wrong. Was there any opportunity for dialogue with NHS England about how guidance might be broadened or be more helpful in avoiding those issues?
There was continuous feedback through the regional teams and through regional. So this would have been led by the chief nursing officer at the time, and there was a chief nursing officer's forum and feedback through that. So I would imagine that it would have been handled through that, but I didn't have personal experience of that.
So you're not aware of whether any concerns were in fact fed back? Or
not the specifics, but I know that was a very active topic of feedback into the hospital.
Thank you. And then lastly from me, do you think that the visiting guidance should have taken into account the impact on healthcare staff of whether visitors were allowed to be present or not?
By which I think you mean that the care delivery would have been improved by the presence of...
Well, we've heard a couple of things. So first, yes, that care delivery can be improved because the presence of a familiar carer can actually help in the delivery of healthcare to a patient. But also we've heard a lot about the moral distress that healthcare staff suffered in having to facilitate end-of-life contact, for example, virtually, or not being able to involve family members and loved ones in decisions about a patient's care.
Yeah, I mean, I think that the answer is, the straightforward answer is, this is what we usually do, and we usually do it because it's of benefit to patients and, and would would address that question of various degrees of moral injury that you refer to. So I think that the answer to that is yes, and that's why that's part of our normal practice. It comes down to this business about balance. We had relatively low levels in some of the wards in Birmingham and Solihull, relatively low levels of vaccination, for example, and so there continued to be relatively high levels of transmission across the population. I think we all acknowledge it's a challenge, but yes, it would have been, of course.
Thank you.
Thank you, my lady.
Mr Jacobs.
Professor, just a couple of questions on behalf of the
Professor,
trade.
if you can make sure.
Yes, I
answers
need
go
to
the
speak into
microphone.
here.
Thank you. Just a couple of follow-up questions on behalf of the Trade Unions Congress on vaccination as a condition of deployment.
Yeah.
You've described the extensive and time-consuming processes in relation to trying to introduce the policy. You've described the impact on staff, both vaccinated and unvaccinated. Given those factors, was it a worthwhile policy?
So I think I'll just turn my back to you if I may. So I think that we have implemented it for new members of staff coming online. So I think that in terms of protecting our patients, then clearly we would understand that to be a valuable exercise in the context of. In the context of staff who had been through the pandemic, I think that one has to accept that there are challenges in the way that that's communicated. I think if my position is it was a worthwhile policy in the sense of if had not attempted to implement it, somebody else would be asking us the question of why we had not attempted to implement it. So hopefully that gives you some feel of the dilemma that we all feel in terms of enforcing a specific treatment or on staff members who are many of whom had contributed significantly to the COVID response.
And you describe in your statement, and I think you've given a sense of this in your evidence, it in a sort of different way to vaccination as a condition of deployment, various approaches of encouragement rather than enforcement, provision of credible information, discussion groups, psychological support and what have you. Do you think those means of encouragement were effective?
I think they were, not completely, as we know. I think the one thing specific that I'd probably bring out is how important information was, because we found that our information was incomplete around those who had been vaccinated or not, and it's really important not to engage in those discussions based on incomplete information. I think that's the other thing I'd add.
And I think it's right, isn't it, Professor, that once the government dropped its vaccination as a condition of deployment policy, as a trust, you reverted to an approach of encouragement rather than...
Correct.
Yeah. And in the context of a pandemic and the sacrifice that had already been made by healthcare workers, is it acknowledged from your trust perspective, do you think, that discussing the value of vaccination with staff who are concerned, providing support and so on is preferable to, and actually probably more effective than saying, take it or you'll be dismissed?
Yeah, I think it's really important if I could address the latter point, the concept that this would have been about take it or you'll be dismissed is not one that we would recognise. That it was very much about working with our employees and our staff side representatives to minimise the chance of that happening, accepting the fact that that could conceivably be an ultimate sanction, but that was never in our mind.
Yeah. Thank you very much.
Thank you, Mr Jacobs. Ms Monroe, please. Ms Monroe's there.
Good morning, Professor. My name is Alison Monroe, and I ask questions on behalf of COVID Bereaved Families for Justice UK. My lady, may I start actually with my last two topics, because these are of particular importance to many of the families that we represent. NICE guidance. Was the NICE guidance, which was published in March 2020, and which I think from your statement you say was being used by QE, was it being used to inform discussions or decisions in relation to any of the following? Escalating care, such as access to ICU treatment, treatment escalation and limitation, the TEAL forms, and DNA CPR notices?
So it was part of the information that we were providing to our healthcare professionals to have individualised decisions and discussions, I should say, around those decisions with staff members. I'm perseverating from the previous question, with patients. And I think I can come back to a point that I made earlier, that a lot of our efforts were around deploying very senior members of clinical staff onto the wards, so those in large numbers, so that there was sufficient time for those discussions to be had in an individualised way.
And still on the topic of NICE guidance, notwithstanding what you've said about the deployment of senior staff, clinicians, was any consideration given to the risk that as a result of the NICE guidance, clinicians may or could perhaps overestimate, for example, CFF scores and associated factors such as age or pre-existing health conditions when making those important considerations of whether a patient was eligible for ICU admission, ventilation, etc., at a time, and context is really important here, of course. This is all at a time when there are severe constraints on resources, capacity, and just the mental and emotional toll that's being taken by the staff themselves.
Yeah, so if I could first of all say we spent a lot of time communicating with our staff around the importance of not simplifying decision-making down into a simple score. And I think you're referring to the clinical frailty score there, and that being very specific in our communication that no decisions should be made on using a score that had not been validated for that purpose, for starters. Secondly, I come back to really the profound efforts of the intensive care response in our hospital to eventually more than double capacity, to allow us to continue and to communicate that the importance of maintaining standard decision making and what have you. And there was a third point I was going to make, which has just gone out of my mind. But I think that's the essence. And I think in my evidence I kind of touched on it, which was the importance of, whilst acknowledging there were huge pressures and what have you, not jumping the gun, as it were. So there were discussions going on nationally about what happens if we end up with the Neil Ferguson modelling coming to pass during the course of April. But it was really important, and we really emphasise this in our communication, not to conflate that with current decision-making. And that was a really important part of the work that we did in across the senior leadership and cascading down. Hopefully that answers your question.
It does, thank you. Then the next topic, ICU admission and decisions on escalation of care. Was QE or the Trust able to collect and collate patient data, for example, age, to understand if there were any changes in the characteristics of patients admitted to ICU during the pandemic?
So we would be able to provide you with that, with those data. Of course, that this is a particular disease, so it was a unique disease in many ways. It's not often, we don't admit many patients with viral pneumonitis, and so you'd have to then compare that with an equivalent patient group, as it were. So I think it's a question that's got subtleties within it.
And then finally on this topic, and it's again relates back to an earlier part of your evidence, Professor, where you were asked about the increase in 2020 and 2021 in the number of patients for whom there were DNA CPR notices in place on arrival or admission to ICU compared to 2019. You referred to an increase of from 2 to 4%. And I think your statement actually, there was some differential between ethnicities, 2.6 to 4%, 4.2 increase for South Asian patients and 4.8 to 8.4 for white British patients. I think those were the figures that you gave, just to assist. And in terms of the teal forms, there was an increase, I think, again, from your statement, from 20% prior to the pandemic to a peak of 60%.
Yes.
So that's quite a big increase there, or is it?
So the point is we're encouraging people to fill in a teal form for everybody. That does not apply treatment limitation. In fact, I think we saw a threefold increase in the affirmation of for all active treatment, for example. So, you know, there is a strong argument that to encourage that every admission should have a teal form or a respect form completed, so that it's absolutely so that it takes away from this lack of clarity, this conflation of determining patient preferences from a specific set of decisions around cardiopulmonary resuscitation. So that's what we're talking about. Can I just, if I may, just touch on the differences, the ethnicity differences so that was for patients coming in from the community, as they came in from the community, had they had a DNA CPR. And of course, there's a very big difference in our population in the age distribution according to ethnicity. So our South Asian population is much younger than our white population across Birmingham, Solihull.
I suppose the question that I have arising out of that increase, on the one hand, one could say that, well, the increase, there's many more people coming into ICU, that could explain the increase in the percentages. But from particularly the perspective of the relatives, and who are not, having that contact, not having that opportunity to discuss with the senior clinicians. Would you agree that at least there could be, those figures, that increase could give rise to concerns that DNA CPR and other decisions to limit care may have been influenced by the severe constraints on resources and capacity rather than strict clinical decisions, particularly, as I say, from the perspective of the relatives?
Well, I can understand why those concerns may exist, and of course that particularly reflecting that early period in March and April 2020 when, there were fears that, we watched the news together of, what was going on elsewhere around the world, what was going on in North Italy, for example. So I can absolutely understand why that might be a source of concern, and it's why information and the use of data is so important in, providing the evidence, as you've alluded to, and we'd be very happy to look in any way that we can at any specific questions that you might have.
Thank you very much, Professor. My question then, going back to the top, my lady, my question on supply of ventilators, that's been answered. Just briefly on masks then, FFP3 masks. Again, you've touched on this in your evidence already, Professor. We've heard evidence during the course of this module, quite a lot of evidence about masks and fit testing and some of the problems, anthropomorphic differences about genders and ethnicities, and how that could influence the adequacy of masks for staff. Did the Trust have access to a range of sizes and models of masks to ensure that staff across the board, women, black and minority staff, who may have failed fit testing, were able to be provided with alternatives? And if not, were there situations or scenarios where staff were being asked to work with masks that weren't fitted properly?
So the answer to that question is no. And the reason actually is that our procurement team did, and I think it is in the evidence somewhere, we managed to procure over 1,000 of the hooded ventilated hoods. So if you were not able to work with a mask, then you were provided with a hood that provided you with protection pretty much whatever your anthropomorphic difference is, or or other differences.
And this is for another module, but it would seem from a number of your answers, Professor, that the procurement team, certainly the QE in your trust, were able to work and resolve quite a lot of the difficulties that potentially were there around supply.
I think they'd probably say some of them.
Some of them. Then finally, in the time left, just one or 2 points in relation to general concerns about supply of PP, ventilators and CPAC equipment. Was it your understanding that PP that was provided from central supplies had not been quality checked in some instances or inadequately checked prior to arriving in the trust hospitals? And if so, did that impose an additional burden on the hospitals within the trust?
I mean, I couldn't say whether it had or it hadn't. I think that our procurement team would say that some of the PPE that arrived wasn't fit for purpose and what have you. You can understand in the going. It's difficult for me to take myself back, but in the levels of pressure and drive to get kit out, I can understand why that might have happened. But it's certainly our observation that on occasion that that the quality control didn't meet our in real life testing.
Thank you very much, Professor. Thank you, my lady.
Thank you, Ms Munro. I think that completes the questions we have for you, Professor Ball. Thank you very much indeed for all that you did, obviously, during the inquiry, during the pandemic, to try to make sure your hospitals were well equipped to serve your local community, and thank you for all the help you've given to the inquiry.
Thank you, my lady.
Very well. I shall return at 20 to 12.
All right.
Steele.
My lady, I would like to call, please, Professor Sir Stephen Powis.
Can you just say in your right hand and repeat after me, please? I swear by Almighty God.
I swear by Almighty God.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth, the whole truth, and nothing but the truth.
Shall be the truth, the whole truth, and nothing but the truth.
I hope we haven't kept you waiting too long, Sir Stephen.
No, not at all, thank you.
Can you give your full name, please?
Stephen Hugh Powis.
Professor Powis, you have given several witness statements to this inquiry, and for Module 3 you've provided 2 witness statements, which we'll be focusing on today. This is INQ 000412890. That's 282 pages long. It's dated the 7th of February 2024, and that's your third witness statement to this inquiry, and that's how I will be identifying it. And INQ 000485652, dated the 9th of July 2024, which is your fourth witness statement to this inquiry, and it runs to 591 pages. Can I check, please, that you have both of those statements accessible to you?
I do.
Thank you. Professor Powis, you're the National Medical Director of NHS England, and you have been in that role, I think, since early 2018. Is that correct?
Correct.
And you're also a Professor of Renal Medicine at University College London.
Yes, I have an honorary chair. I was a substantive professor until I left for NHS England, and then I was given an honorary chair.
and you were previously Medical Director and latterly Group Chief Medical Officer of the Royal Free London NHS Foundation Trust from 2006 to 2018, is that right?
That's correct.
And you were not, I think, in clinical practice during the pandemic.
No, I stood down from clinical practice temporarily. A couple of years before I left the Royal Free, we had additional work to do that required me to do that. And then when I left to come to NHS England, because of the nature of my clinical work, which was looking after long-term transplant patients, I didn't feel it was going to be possible to do that to the satisfaction of staff and patients, and therefore I elected to stay out of clinical practice.
Thank you. I think during the relevant period you held a number of roles and responsibilities which you've set out in your witness statement, but perhaps I can summarise them in this way. You were an NHS England board member,
yes,
a member of the National Incident Response Board. You deputised for Lord Stevens, the former Chief Executive of NHS England, at government meetings. You attended SAGE meetings regularly. And I think you were also the Interim Chief Executive Officer of NHS Improvement between the 1st of August 2021 and the 31st of July 2022, on which date NHS Improvement was abolished and legally became part of NHS England. Is that right?
All correct.
You've explained that NHS England is an executive non-departmental public body sponsored by the Department of Health and Social Care, but is it correct that that has a degree of autonomy from the Secretary of State?
We have a degree of autonomy as what's commonly known as an arm's length body, but clearly we work very closely with Department of Health and Social Care and with the Secretary of State.
And could you please briefly outline for us the role of NHS England in the NHS system in England?
So NHS England is fundamentally a commissioner of services, although with the merger of other organisations such as NHS Improvement, NHS Digital and Health Education England more recently, it has taken on a wider role. For instance, it has some regulatory powers as well. But fundamentally, it's a commissioner and a coordinator of healthcare across England, and also has an oversight role in ensuring that healthcare services are delivered. The government gives us a mandate regularly, asking the NHS, or indicating to the NHS what it wishes the NHS to focus on. And for example, each year we will translate that into operational planning guidance, which is then provided to NHS organisations.
And is it right to say that NHS England therefore does not provide healthcare services, but rather commissions them or oversees commissioning?
Yes, as I'm sure you know, the NHS is an ecosystem of many, many organisations, many of which are their own statutory organisations. And of course, when it comes to primary care and general practice, they are independent businesses with whom we have a contractual relationship. So we don't provide those direct services. We provide a few patient-facing services, particularly since NHS Digital has come into NHS England, but that was after the relevant period.
Thank you. Your third witness statement sets out that NHS England is a Category 1 responder under the Civil Contingencies Act and maintains an emergency preparedness, resilience and response plan to enable it to respond to a wide range of incidents and emergencies, such as a pandemic. And you've also set out that throughout the relevant period of this module, which is the 1st of March 2020 to the 28th of June 2022, NHS England was operating at an NHS incident level 4 or level 3 at different points throughout that relevant period. Could you please explain to us what level 3 and level 4 meant in operational terms?
So level 4 is the point at which NHS England takes a much more direct command and control role within the system. So, for instance, that means much greater oversight of data collection, much greater operational input, much greater control and oversight of supply chains, for example, more involvement in issuing guidance through to healthcare providers and healthcare systems, and that is coordinated at a national level. Level 3 you could think of as very similar, but the coordination is at regional level rather than national level, and is most suited to when there are regional variations in the incident or the incidents are occurring within a single region.
And when we say at regional level, I think it's right that NHS England has divided England into, I think, is it 7 different regions?
Yes, over the history of NHS England, there have been a number of different configurations, but there are, I think from the start of the pandemic and currently there are 7 NHS England regions.
And can you help us with this? How would NHS England operating at either incident level 3 or 4, how would that affect individual hospitals and the clinicians working within them in terms of how they were able to work during the pandemic?
So it would mean that we would have a much more coordinated and collaborative response. So clearly level 4 gives us a greater degree of direction, but I think it's also important to say that clearly that direction occurs through also giving individual organisations a flexibility to respond how they need to respond in terms of their local context, their local geography and local population. That's particularly relevant in a pandemic when infection rates might be different in different parts of the country. So I would characterise it as bringing the health system much more together as a single entity than you might normally see in normal times.
So there's less local discretion in terms of how, as you say, infection prevention and control measures might be applied or visiting restrictions?
Yes, potentially, although I think it's important to say that we would always want to give local discretion because local circumstances are always different, and there is never one size fits all. No guidance or instruction can perfectly fit into every individual setting. Clearly, at the height of the pandemic, at waves, then we're likely to be giving guidance that is more uniform and more directional, but at other times it's quite right to give local systems more flexibility to reflect those local contexts. And I've given one example when infection rates are different in different parts of the country.
We may come back to that level of local discretion in relation to some of the specific topics that we're going to address, if we may. Can you help us with this? How was your role as National Medical Director? How did that change during the pandemic? Perhaps you can start with outlining how that role operates in business as usual.
Well, as business as usual, my role is to advise the board of NHS England, predominantly on clinical and professional matters, but not just that. As part of a collective unitary board, then I obviously have a collective role within the board on all matters that NHS England might need to consider. I have a particular professional role as a doctor, the most senior doctor within the NHS. I have some statutory roles around professional regulation. There are a number of programmes that I run within my directorate in NHS England around cardiovascular disease, stroke, prevention, diabetes, for instance. That's in normal times. And of course, that is useful in a pandemic because that's where that expertise sits. But during the pandemic, I was much more pulled into, for instance, advice to government and advice to ministers, much more pulled into media and public-facing tasks. You will be aware that I did over 30 Downing Street press briefings, for example, and obviously pulled into assisting with the overall operational role. I had a particular role around data and modelling. There was a cell that looked after that, and I was a senior sponsor there. I was a member of the Senior Clinicians Group, which you will have heard from other witnesses, was a group of senior doctors and other clinicians that came together across England, but then across the 4 nations. I was a member of SAGE from late February, as you outlined at the start. SAGE was often meeting twice a week, and there was obviously preparatory work to be done and occasional papers to take to SAGE. So the change for the pandemic was much more and almost exclusively into those pandemic-facing tasks. One other role I should mention was around working and coordinating with our partners and stakeholders, so the Royal Colleges, the BMA, others, charity sector. I would meet with all of those on a much more regular frequency and cadence than in normal times. So at times I would be meeting with the Royal College presidents twice a week for a flow of information both ways.
You mentioned there your role in relation to data and data modelling, and I wondered if we could now come on to NHS England's access to information during the pandemic and how it collected data from the system.
Yes.
So if we can go back to the the early days of the pandemic, at the beginning of March 2020, when information was emerging from China about the novel coronavirus, when Italy was experiencing high numbers of severely ill patients with COVID-19. What were NHS England's sources of clinical information on COVID-19 and how it affected patients and how that was likely to affect the healthcare system of the UK?
So we had a number of sources of information in the period between January and coming up to March. One of those would be through colleagues in Department of Health and Social Care, for instance, the Chief Medical Officer and the Deputy CMOs. Their role is much more internationally facing than my role and the role of NHS England, for instance, liaising with the World Health Organization. That would be one source of information. We would get information from our national clinical directors and national specialty advisors. So they are senior clinicians who we part employ within NHS England. They also work in their host organisations, and they have expertise in areas such as respiratory medicine, critical care, end-of-life care, and as respected and experienced individuals within their specialties, they will be gathering information from specialty societies, for instance, and from colleagues. If I give a personal example, I'm a kidney doctor by background. Throughout the pandemic, I maintained membership of the International Society of Nephrology, the American Society of Nephrology, the American Transplant Society. So I would, on a daily basis, be seeing information coming through on emails, on web pages from those specialist organisations. So that played a key role, and that information was transmitted to NHS England. Then, of course, there's a published literature, and papers in the literature started to be published shortly after the pandemic started, so we would be paying attention to those as well. So there were multiple sources of information. Our job at NHS England was to collect that information and operationalise it. It was not our primary responsibility to be in contact with people overseas, although we did have some contact on occasions. We would much more be sourcing that data from colleagues, both in other departments and organisations. Public Health England would be another that I would mention, and also from clinical colleagues throughout the system.
When you talk
Can I
about
ask you to slow down, please?
Certainly.
When you talk about operationalising that information or that data, how did you or how did NHS England disseminate that evolving clinical knowledge about COVID-19 and how it affected patients and the clinical support that they would require? How was that information disseminated to clinicians working on the front line?
So very early on, we had a conversation with NICE around the dissemination of clinical guidance. As an organisation, we do clearly disseminate guidance, but we don't regularly and typically disseminate best practice guidance in the way that NICE has a particular role. But it was clear from the outset that this was going to be a period where it was going to be very important to provide clinical guidance, and therefore we stood up the machinery, the mechanism to do that, and we agreed with NICE that we would essentially lend a hand and take part responsibility for issuing that guidance. So I think we issued about 67 or so clinical guidance documents, often more operational than best practice, and NICE similarly issued guidance as well. As Wave 1 started to, as infections came down at the end of Wave 1, we handed that particular responsibility back to NICE. But during the first wave, we were producing guidance on quite a frequent basis. And if you wish, I can talk about some of the pros and cons of that approach.
If we can come on to guidance, I think, a little later,
Certainly.
If we may. You've given an example in your witness statement of how very specific information was cascaded to the system, using the central alerting system, which I think is managed by the MHRA, the
Correct.
Medicines and Healthcare Products Regulatory Agency. And you give the particular example of using the CAS to alert clinicians to the effectiveness of dexamethasone in June of 2020.
Yes.
And you explain there that NHS England cannot post alerts directly, but has to go through the Chief Medical Officer's office. Do you think it would have been beneficial if NHS England had had direct access to that system?
Not particularly, because we work very closely with the Chief Medical Officer and his office, and there's no delay in getting a CAS alert out, so I don't think it would make a great difference. And of course, CAS alerts are very important, particularly in directing very specific information to the attention of clinicians, but there are a whole range of other ways in which we communicated out information, as I've set out in the statement. So that would be through webinars, which we undertook frequently. It would be through letters to healthcare providers and healthcare systems. It would be through bulletins that we stood up increasingly. I had my own medical director's bulletin that went out to medical directors regularly. It would be through those conversations with the Royal Colleges, the BMA, and other important partners. So there wasn't one route of communication, there were multiple routes of communication, all of which had benefit and could be used for different purposes and potentially different audiences.
So some of those channels of communication, and indeed some of those bodies that you've mentioned, are England only,
yes.
And some of them are national bodies, for example, the Royal Colleges. So can you help us with this? Was there any means by which this sort of clinical knowledge and evolving understanding about COVID-19, was there any way that could be shared by NHS England with healthcare systems in the devolved administrations?
Yes, that would predominantly happen through the Chief Medical Officers, who of course meet regularly as the 4 Chief Medical Officers of the 4 nations of the UK. But also, as you rightly say, the colleges are UK-wide, and the Scottish colleges were members of my webinar as well. They have many English members as well as Scottish members, and on occasions we can talk directly to colleagues in the devolved administrations. But you're quite correct, the focus of NHS England, of course, is primarily within England. As a general principle, and I think the Chief Medical Officer may have given this in previous evidence, we would want to align clinically between the 4 nations as much as possible. And I think from the senior clinicians in those 4 nations, that was the aim. Of course, we have to recognise that they are 4 different political systems and health is devolved, and therefore there is that context. But as much as possible, we were trying to align clinically.
Thank you. If we can keep with the topic of information, but move on slightly to information about the NHS system itself and the data that was collected. Is it right to say that in order to coordinate the national response, NHS England needed to greatly increase its data collection about the capacity of NHS hospitals in terms of bed numbers, occupancy rates, staff availability, medical equipment and so on?
Correct, and if I could give some additional context, as you would expect, because of its role, NHS England does regularly collect and publish healthcare data from healthcare systems and healthcare providers. We collect information on the amount of elective care that is undertaken, on performance in A&E departments. You will see that published every month on a regular basis. Many of those collections have a lag on them. In other words, they are collections that are made many days or weeks after the patient episode. And there is good reason for that, because that gives us clarity on the diagnosis, on the treatment and the management. We have some collections, and the urgent and emergency care collection was the collection that we had begun a few years earlier that took more real-time data to give us a more real-time understanding of what was going on in the emergency pathways within the NHS. But you will understand that having a lag on data is not optimum in a pandemic where things are changing on a daily and hourly basis. And so we had to move to a much more to a system that was much more real time. And therefore we developed a Sitrep, a specific Sitrep, which collected data every day. In addition to that, there were lots of individual data collections for particular purposes, which I'm sure we can discuss.
So if we can look at Sitreps, please. I think there were several Sitreps that were collected on a number of different aspects of the healthcare system. And I think if we can focus on the NHS provider daily Sitreps at this point, I think it's right that this changed over time to collect data on different categories, for example, of bed types, in order to reflect the understanding of the clinical support that COVID patients in particular were going to require. Is that right?
Yes, clearly our principle is only collect data if it's going to be useful and operationally useful, because we understand the burden of data collection that we place upon organisations and individuals, and we can discuss that later if you so wish. But the data collection evolved over time. It evolved firstly as we learnt more about the virus. That necessitated more collection. Secondly, it evolved as we began to understand the operational challenges. And so some of the things that we collected over time, information on staff absences, for example, which obviously would have an operational impact. On nosocomial infection, we collected data specifically on that as well.
It might assist here if we can go to the statement of your colleague Amanda Pritchard, the Chief Executive Officer of NHS England, page 106. Thank you. Because she sets out here a timeline of the evolving changes to the NHS daily provider Sitrep. And so we can see here at B, between the 10th and the 16th of March 2020, NHS England's existing Sitrep reporting was expanded to include the number of patients in hospital with COVID-19 and how many of these were in high dependency unit or intensive treatment unit beds. And is that the difference between level 2 and level 3 care? Yes. And those figures were shared with the Department for Health and Social Care. And can we go over the page, please? And we can see at E that on the 26th of March, Sitreps were expanded to specify the number of patients receiving oxygen, non-invasive and mechanical ventilation, and also including reporting from independent sector providers on how many NHS patients were being treated there in critical and non-critical care beds. Looking at that expanded data on oxygen, non-invasive and mechanical ventilation, if we can go down to F, we see that these were then specified as O, O plus and V. So would non-invasive ventilation include CPAP? We've heard something
Yes,
about
it would. So non-invasive ventilation is essentially O+, and it would include CPAP. It's where a patient does not require to be intubated, in other words, a tube put into their trachea and sedated in order to provide ventilation.
So mechanical ventilation would require
that is mechanical ventilation. Non-invasive ventilation typically is a tight-fitting mask through which oxygen is delivered, typically at a higher pressure.
And oxygenated support, would that be oxygen without a mask?
It would be through a mask or through nasal tubing, but it would be what you would routinely see as giving people extra oxygen. So simply increasing the oxygen concentration.
So that wouldn't have to be provided in either HDU or...
simple oxygen can be provided in many settings. They'd be typically provided in wards, but it obviously can be provided in high dependency units and critical care units, level 3 units. Typically, if a patient only required simple oxygen, an increase in oxygen concentration, that would not be a reason for moving to an HDU or a critical care unit. The patient would need additional support in order to make that escalation.
And so why was it so important to specify the beds or divide them up in this way, O, O plus and V?
Because the operational requirements around those different forms of treatment are very different. For patients who are ventilated, clearly those are the sickest patients. They will need very high input from staff. They will typically need to be managed in critical care facilities, although they could be managed in surge areas, and increasingly that happened as we provided the equipment and the support to do that. At the other end of the spectrum, as I've said, simple oxygen through a face mask can be provided on a normal ward, doesn't require any particular additional equipment other than the mask and, of course, the piping to provide the oxygen, and it doesn't require the sort of intensive staff oversight and monitoring that obviously somebody who is intubated, who is sedated and is undergoing mechanical ventilation requires. So it gives us an indication of the necessary deployment of resource and staff. And depending on the proportions of patients in all of those groups, that would have a very different impact on the workforce and on the resources that we had to deploy. And indeed, if I give you an initial bit of context, particularly in February, as the risk of a pandemic occurring and coming to the UK was obviously increasing substantially, we undertook a lot of work to try and model and predict what proportion of patients would be in each of those categories, because clearly that was going to have an impact on the services that we needed to provide.
Thank you. If we can go down to point H, please, here. Sorry, point J. We see there that in October of 2020, the daily Sitrep collection expanded to include reporting breakdowns by reference to ethnic background, more granular age brackets. We have heard that data collection or data coding on ethnicity in the NHS system is often missing or inadequate. And that the grouping of ethnicities tends to be very broad and lacking in granularity. Were there any data collection or coding issues that were apparent when this data collection for the Sitreps began?
Not that I recall, although very happy to check for you, but we did feel it was, and you are quite correct, there are challenges around collecting ethnicity data. We are always striving to do better. But
has that changed? Have there been any changes made to the way that ethnicity data is now collected or coded in the NHS system?
I think the focus is on collecting the data and filling the gaps rather than necessarily simply changing the underlying coding and collection. But again, very happy to check and give you further information on that.
Thank you. We can take that down now, thank you. So the Sitrep data was collected by NHS England. It's sent in by individual trusts or hospitals. Is it then to some extent relying on the accuracy and the timeliness of those Sitrep requests being completed and sent back?
Yes, absolutely. And of course, there are pros and cons of collecting data, in essence, in real time. So, as I said earlier, in those data collections that take longer to collect, there is an opportunity to validate the data, there's an opportunity to check the data. So it is as accurate as possible. When you are collecting data, as we were in the Sitrep, that is collected in organisations at 8 o'clock in the morning and is essentially made available across key decision makers and across the system by lunchtime, the opportunity to verify the data, the opportunity to check its accuracy is very limited. And if you looked in detail of those data sets, that Sitrep, you would see from time to time an obvious error where a hospital has entered a number of patients. It is clearly vastly different from the day before or the day after. And clearly somebody has entered a wrong number. But the principle was that the benefit of getting that data as quickly as possible outweighed any disbenefit from the occasional error in the data, because it was designed to give us a system-wide overview, and that the small errors that occurred in individual organisations did not impact upon that.
Can we look briefly, please, at that system-wide overview? Can we see one of the... thank you. This is, I think, a dashboard. Mm-hmm. This is from collating the daily Sitrep data.
In fact, I believe this data was collected separately from the Sitrep. This is data, I think, from the alpha wave in January 2021, the 23rd of January 2021. And this was data that came direct from critical care units in order to assist with the process of delivering mutual aid to organisations that were running out of capacity.
So that would be if a patient had to be transferred to a critical care unit.
But the principles are the same in that the data would be collected in real time, and of course it would be the same source of data in terms of bed numbers and patients in beds that would be collected through the Sitrep.
Can we have a look then at some of the categories of data? Plainly, 23rd of January 2021 was a time when the system was under considerable pressure. We see a lot of red on this dashboard. But if we can look in particular at the kind of information that's collected and how that's being presented, we see at the top baseline beds. Does that mean the number of beds that were not considered to be surge capacity, but the number of beds that we started from?
I believe so, but I can't give you the exact date information on when that baseline collection was made. But yes, you are right, that would be baseline core capacity.
And we see beds within ACC adult critical care?
I believe so.
Surge beds, so these are over the baseline.
These are beds that we would have surged into other areas as part of the surge plan, so that would typically be theatre recovery areas, even theatre spaces, spaces where it is possible to provide critical care, but requires an increased effort, and they're not designed to do that on a permanent basis.
And we've also heard that means a stretched staffing and nursing
Absolutely.
ratio as well.
Absolutely.
Yeah. And then we see total beds up in 48 hours. Does that mean beds that can be made operational?
So I believe that would be a prediction of the beds that are likely to become available based on local knowledge of patients who are likely to be discharged from ITU.
And we can see, moving down, occupancy against baseline beds. So at this point, all the baseline beds are occupied 100%, and 51.6% above base, 42.4% above beds within adult critical care. So does this mean that 51.6% of the surge capacity was being utilised?
Well, I think what it means is that there were 51.6% above baseline. I am not sure that it would give you on this dashboard. I'd need to do the maths to work out how it relates to the actual surge beds available. But what it clearly shows is that there's pressure, as you would expect at this point in the pandemic when we were at or close to a peak, and that the critical care units were operating above their core capacity.
And we can see that occupancy against total beds is 90%. So
yes,
that tends to suggest that taking baseline and surge capacity together, 90% of those total beds were occupied.
Yes, correct. That would be the figure for that.
And if we can look quickly at the coloured numbers, pastel coloured numbers in the right-hand side of this black panel, we can see that COVID suspected or COVID positive patients on invasive ventilation, the numbers are given there, non-COVID patients on invasive ventilation, COVID positive or suspected patients on non-invasive ventilation. You've explained that would include measures such as CPAP.
Yes.
Similarly, for non-COVID patients on non-invasive ventilation. And then we've got HFNO patients. Is that high-flow nasal oxygen?
I believe so, yes.
And for both COVID and non-COVID patients. And then patients that are on some other form of support. We can take that down. Oh, one final thing we should probably look at here. If we can scroll down a little bit, please. We can see that there are a number of hospitals listed there. We don't need to go all the way down because this is a spreadsheet that goes on for a long way. But we can see that the CritCon score, 3A, 2A, 2B, is recorded there, and the nursing ratios and the total number of patients. And then we can see the declared available beds, 0 or 1. For a lot of those hospitals.
Yes, and I think this gives you a real insight into the sort of granular data that we were collecting and had to collect in order to perform our duty and responsibility under a level 4 incident. And this, as I said at the start of this particular exhibit, was giving our central team in cooperation with regional teams the information that they needed to understand which hospitals required the most support and were either at the point where they needed mutual assistance, in other words, assistance from other hospitals, or were getting close to it. I mean, clearly that is the purpose of the CritCon score. If you've heard from other expert witnesses, you will know that CritCon 3 is a position where people are getting close to the point that they need that mutual aid and it needs to be considered. You will see there are no CritCon 4s there that are the point at which they have absolutely run out of capacity, and it's a mix of 2 or 3.
Thank you. Perhaps we can take that down now, Lawrence. In terms of the CritCon levels, we have, the inquiry has heard evidence from Professor Kevin Fong, who undertook a peer support programme going into critical care units that were under a great deal of pressure. And he referred to the fact that the data collection forms, at least at first, were very onerous. And he said that it was clear that those units under the most stress provided the poorest data returns, indeed until the point that they became so operationally stressed that they provided no returns at all. So those that you wanted to know the most about were the least likely to return in the first wave. Now, he was speaking about CritCom reporting rather than Sitreps. But were there any issues that you were aware of with those trusts under the most pressure not sending in Sitrep data?
So every day on the Sitrep, there was a list of missing trusts where data had not been submitted. I looked at that Sitrep every day, and the list of missing trusts was usually small, often none, and typically, I think, less than 5. We can provide that detailed analysis, I'm sure, but from the Sitrep information, I certainly didn't get the impression that trusts were not submitting data, although I recognise absolutely, and we recognise at NHS England, that this was an onerous task for trusts, and as ever, it's a balance between ensuring you're getting the information, which of course then benefited those organisations in turn, because that's what it was being used for, but not placing too much of an onerous task on them at a time when they were clearly stretched, as Professor Fong had said, and clearly very busy.
Do you have any reflections now, with the benefit of hindsight, on how NHS England could improve data collection on these sort of categories in the event of a future pandemic where it's going to be important to have accurate real-time data, so that it's possible to get good quality data without overburdening the staff who are providing care?
Yes, and I think this is a comment in data collection in general, because we collect a lot of data when we're not in a pandemic, and that data is really important and useful clinical information that guides clinical treatment and improvement in clinical care. So over time, I would hope that we could extract that data directly from electronic patient record systems, and therefore it would not require text, paper entrance or separate systems to enter it onto a computer as part of us filling in a Sitrep spreadsheet. I think we are making progress towards that, but of course that requires a lot of technical infrastructure. It requires every organisation to have an electronic patient record that could do that, and to capture the information that we would require. That will be a long journey, but that is the destination that I would like to reach.
Thank you. One final point, please, on data collection. The inquiry has heard from Professor Sir Chris Whitty previously, who emphasised how important it is to have data on healthcare worker deaths during a pandemic. Am I right that there was a lack of clarity or some disconnect over the way healthcare worker deaths were counted during the pandemic between the Office of National Statistics data and the NHS England records?
So we did collect healthcare worker deaths. It was not a trivial task in getting that information and absolutely defining everybody who was a healthcare worker. We put a considerable amount of effort into doing that.
And how was that data obtained? Was it obtained anecdotally?
It would be no. It would be obtained from collecting. We set up a specific reporting system to report both patient and staff deaths in the first wave. That data is available. I can't give you the exact details, but I would suspect it is different from the way the ONS collects data. ONS typically collects data through death certification, for instance. We would be collecting the data directly from organisations.
Perhaps we can have a look. There's a table at your witness statement, page 230. Thank you. I think it goes over the next page. So this is a table of all the NHS England recorded deaths of NHS staff. We can see that the total there is 559 people who died during the pandemic from COVID. And we can see that there's a breakdown there by ethnicity. And I think you've explained in your witness statement that it wasn't easy to record those deaths because there hadn't been a formal system in place previously. Are you satisfied that there's now a suitable system in place for capturing data on the deaths of healthcare workers, and particularly in relation to race and ethnicity data?
Well, I think there's a better system in place, and as I said, we put a lot of effort into standing up this particular collection of data, and it wasn't without its challenges. I'm sure that there is more that we could do to perfect that, but I think we have learned a lot from doing this.
Thank you. We can take that down. Thank you. So moving on from data issues, if we may, can we look at NHS England's role in clinical guidance, both in drafting it and in disseminating it? You mentioned earlier that you took a role that NICE would normally perform at the beginning of the pandemic. I think you produced both clinical guidelines for the management of COVID-19 and also assisted NICE in developing some specialty guides as well. Can you explain why it is that you took over that role from NICE before handing it back, as it were?
Because we recognise that in a healthcare emergency, such as a pandemic with a virus, which had previously been unknown, where the evidence base of the impact of the virus was developing rapidly, that there was a need to try and inform clinicians of how clinically they might best respond to that and what best practice looked like. And it goes back to my earlier comments around our role in assimilating the information that we're getting from colleagues, from the published literature, from overseas, and synthesising that both in terms of how to manage a patient, but also in terms of the operational requirements to fulfil that management. If I give you two examples, so it became clear to us at the start of the first wave that it was probably better to try and manage patients with non-invasive ventilation than always proceeding to mechanical ventilation. That was information that was coming out of colleagues in Italy and other places that were managing the pandemic, and so we were transmitting that information through to clinicians into the system. Another example in my own specialty in kidney disease, it wasn't apparent at the start of the pandemic that many of the patients who developed severe COVID would also develop kidney failure, acute kidney failure, which would require dialysis treatment to manage that. That became obvious as we went into March and into April, and therefore we communicated that out to clinicians. We worked with our National Clinical Director or equivalent for renal medicine and the renal community, the kidney community, to ensure that we had the stocks in place, the consumables in place, and the ability to deliver acute kidney care, which sometimes did require mutual aid as well.
If we can focus on the guidelines particularly that were published by NHS England, you've explained that you had to adapt or adopt a new process for developing those at pace. Yeah. Can I ask whether any part of that process of developing guidelines involved any stakeholder consultation or consultation with, for example, disability groups, or was there not time to do that in the...
As much as possible, but again, this is a recognition of balances. Clearly, there are pros in developing guidance quickly, particularly, as I have said, in an emerging pandemic where the need to get information out rapidly is paramount. But clearly there are also downsides. You can develop guidance too quickly, and you can equally develop guidance too slowly. The benefits of doing it over a longer time frame, which is typically what NICE do, they take many weeks, is that you are able to do that consultation, that verification. So that was compressed.
So is the short answer to that no? The
short answer is we did what we could, but there is a trade-off between getting guidance out rapidly and doing the consultation that you would want to do under normal circumstances. It's a set of lousy choices often, but you have to make that judgment. Of course, at different times of the pandemic, there is an opportunity to take longer over guidance.
But focusing on that early period of time.
On that early phase, particularly when everything to an extent was unknown, the need to get guidance out rapidly took precedent over the luxury of being able to, but not the luxury, but our desire to ensure that we spent an appropriate amount of time consulting and developing guidance in partnership.
Thank you. Can I ask you this? Were any of the clinical guidelines that were developed by NHS England prior to NICE resuming that role, was there any process by which they were disseminated to or for the benefit of any of the devolved administrations?
I cannot recall whether we would have directly sent them as a matter of process, but there was no particular issue in their availability. And of course, once we had distributed them, they would be accessible to anybody who wanted them actually throughout the world. So clearly colleagues in the devolved administrations would have availability to them. Typically, we would not have developed them directly with colleagues in the devolved administrations, although it may well be that that clinicians who were developing might have spoken to colleagues in some examples. But as I said at the start, we're in NHS England. We start this from an English perspective, although we did want to do things as collaboratively as possible.
Thank you. If we can move on, please, to a very specific aspect of clinical guidance. I think it's correct that in March 2020, you were involved together with the 4 chief medical officers and others in work to commission national clinical prioritization guidance, and specifically to develop a decision-making tool to be used in the event that demand for critical care exceeded capacity. And I think a draft was put together and made available for NHS England to review on the 28th of March 2020. Were you made aware that there were clinicians who wanted national guidance on this topic?
Yes, at the time and subsequently, and clearly you have heard that from expert witnesses that have given evidence to the inquiry. I think this is a really difficult issue. I've reflected on it a lot. I'm very happy to discuss it in detail with you.
Can we look, please, at the finalised version, I think, of the draft tool, which is 87 INQ 0000087353. Thank you. We can see that there are 3 different factors, areas, that are ascribed on this tool a numerical score. So first of all, we've got age and a number of points given, greater number of points for older patients. We see the clinical frailty scale and a number of points given depending on where a person sits on the clinical frailty scale. And if we can go back, please, to the... Thank you. And we also see the third box there is comorbidities, and certain specific comorbidities are also given a particular score. And then if we can see the final tool, the total is the sum of the 3 domains above plus taking off 1 point if the patient is female. Do you know whether at this point, at the end of March, when this tool is being finalised, there were any caveats on the use of the clinical frailty scale in terms of it not being applied to patients with stable long-term disabilities, learning disabilities, autism?
So I think separate to this decision tool, we were very clear that the clinical frailty scale was not relevant to people with disability or learning disabilities. NICE had issued some guidance earlier in the pandemic, a few weeks earlier, which had included the clinical frailty scale. They withdrew that, and we wrote out at the time to inform people that it should not be used, it's not appropriate. But in terms of this decision tool, which was never authorised, it was never officially released, it is exactly as you see in front of you. It didn't go beyond this stage other than the group that developed it subsequently published a version of it in a intensive care society set of principles around decision making.
I think we'll come on to look at that shortly. I think the impetus for this had come from, it was the Department for Health and Social Care who had made inquiries to get this tool developed, but then I think on the 28th of March directed that it shouldn't go ahead.
So it would
What
be
was the
useful
reason?
if I gave you some context. I mean, clearly this was at a point in March where cases of COVID were rapidly increasing. The strategy that the NHS and government had taken was, on the one hand, to put in social distancing messages, social distancing, in other words, lockdown, to reduce the rate of transmission. And within the NHS, our job was to surge capacity. But at that point in March, the number of patients with COVID in ITU beds was doubling every 5 to 7 days. We couldn't see, because there was no community testing at the time, what was likely to come ahead. It was not clear whether the public would respond to lockdown. They did wonderfully, but that was not clear. Frankly, I was personally terrified that the NHS was going to be overwhelmed, and doctors were going to be placed in a position, and other clinicians, where they would not be able to make the professional judgment that they usually make in terms of treatments and escalation. And in those circumstances, as I had said to the Health Select Committee earlier in March, I and my clinical colleagues, the CMOs, felt that we should begin to explore a decision tool such as this.
So if I can stop you there, because I think we understand the context in which this was being discussed.
Yep.
What I would like to know is the context in which it was halted.
So it was halted, I think, because a number of us, the Chief Medical Officer and myself, with input from the Chief Executive of NHS England, came to the conclusion that it should not be released. For me, and I have said this in the statement, the main reason was at this point, when it had got to this form, it was becoming increasingly clear to me that the peak of the pandemic was approaching, and therefore it would not be needed because we would not breach capacity. This, as you've heard, is a CRITCON 4 situation, and it became very apparent to me that it was not going to be needed, and I had a fear that if it was released, it might be used when it would not need to be used.
Was there not also a great deal of concern within the Department of Health and Social Care that this tool was going to be very controversial and risk a poor reaction from the public?
Yes, and I had that concern too. And it goes back to the discussion we have just had about developing guidance rapidly, and the inability to consult and the inability to take in a broader set of views. Now, this is not a criticism of the group of clinicians who worked on this. They did a magnificent job. They were asked to do something that nobody ever wants to do, is to develop this sort of tool, and they had to do it rapidly. But it became absolutely clear to me that this was going to be controversial, that it hadn't had the opportunity to be discussed more widely with patient groups, with the public. And so my recommendation to the inquiry is that we should absolutely in future not try and develop one of these tools in the midst of a pandemic. This is a discussion that has to occur in normal times. In my view, it's a discussion that shouldn't be government-led. It shouldn't even be led by the profession. It needs to be located within society. I think that is similar to what you have heard from other expert witnesses. Dr. Sundarangam and Professor Summers, I think, made a similar point. This is too hard a task to do at the height of a pandemic.
Can I just, I'm sorry, it probably doesn't take us very far in the course of this inquiry, but I'm just fascinated. Looking at number 1, the clinical frailty scale, you add a point for someone who's very fit? I'm just not sure. How does that work?
So I think you are pointing out the difficulties in this scale. And again, without any criticism of those who developed it, because they did a fantastic job in getting this far. You can see if you go back to the tool that Greater than 8 is a cut-off point between escalation. You can arrive at that by adding somebody who is 80 to somebody who is well and has hypertension, high blood pressure. It is a useful aid, and in a sense, it reflects what clinicians do, which is they never take age into consideration alone. They always take into consideration other conditions, when the patient's frail, that holistic approach. But to try and simplify it into a scale, I think takes away all the nuances and complexities that come out from the care and interactions between a professional clinician and a patient. And I think that goes to the heart of the debate, because I did hear, and I continue to hear, and it was in evidence that you have heard, that doctors, if we did get to, or clinicians, if we did get to CRITCON 4, would be uncomfortable around making those very difficult prioritisation decisions without some sort of framework, some sort of authority from government. On the other hand, at the opposite end of that spectrum is the view that the last thing we want to do is to take away that judgment and that knowledge in those decision makers from individual decision makers. It becomes too simplistic. We will get on to DNA CPR, I'm sure, and that there might have been inappropriate use of DNA CPR. There is a danger that there might be inappropriate use of a simple tool that takes away from that professional judgment and professional relationship. So this is a very difficult area where there are, in a sense, contradictory and competing views that are hard to reconcile. But it does, in my view, require a debate in society if it is going to be taken further, rather than a debate within the profession or a debate within government.
Do you think there's an element in which, in the halting of this tool at that particular time, because of concerns about how it was going to land, and we can go to the emails within the Department for Health and Social Care if that's necessary, but do you think there's an element to which broader political concerns about public reaction perhaps trumped or overrode clinicians' legitimate concerns about being put in an impossible position? And do you think that was the correct balance to strike, to give a certain primacy to the anticipated public reaction rather than the concerns and views of frontline clinicians?
Well, fortunately, we didn't need it because, as I said, we were reaching the peak of the pandemic. So in a sense, we didn't have to have that debate, a very difficult debate. I think, as I've outlined, I think there are a range of legitimate views here. Another view, which you could have on this, is it's a form of government-imposed rationing if it's taken forward, if it comes from the government. So I think this is a really difficult area. I've reflected on it a lot.
Do you think the balance was right, though? Do you think...
Well, I think it was right to stand it down. I think it was right to stand it down because we didn't need it, and it could have been used inappropriately.
Can I bring you back on that? Because at that point, as you say, reached the peak of wave one, but it was also, wasn't it, foremost in everyone's minds that there was quite likely to be a second wave, yes, and that might be worse than wave two. Yes. So it may be that there was going to come a point in the relatively near future when critical care may be overwhelmed.
So I've reflected on that as well. And first point I'd make is the authors or the group who undertook the work, as I've said, subsequently published it in a set of principles, and I thought that was actually a good position to reach for the pandemic. It included a version of this, but without the scoring, and it focused much more on the principles of how you would make those decisions. I thought that was a good point to reach in the COVID-19 pandemic.
Did you think it was preferable then, if I can just pick up on that, did you think this was preferable without the numerical scoring?
Well, I still think there are difficulties in using a tool even without the scoring, but I think we reached a reasonable position in the Intensive Care Society publishing a set of principles around this and how CRITCON is used. Between waves, we were still in a pandemic, and I still think that to do this sort of thing, if it does need to be done, it is one of those things that I think would require months of consideration, and not in the midst of a pandemic.
In terms of removing the numerical scoring, because we know that that's, I think, the Intensive Care Society tool that was published in Wales as well as in England, remove the numbers. Does that also bring with it a risk that this is going to be interpreted or applied in an inconsistent way, in the sense that if a numerical score isn't given to each one of these, one clinician might accord greater significance to age alone, or might accord greater significance to the clinical frailty scale score, or indeed a comorbidity. So isn't there a risk of inconsistent decisions being made if we don't have a numerical scoring system?
Those are all potential risks, but I think what we are highlighting in this discussion is the difficulties of this sort of tool, and which is why I think it requires further discussion, and that discussion needs to be a broader discussion and needs to be done at a time when we're not in the middle of an emergency.
And with the tool that was eventually published by the ICS, do you know to what extent that adapted version of this tool was utilised in intensive care units in England?
I can't give you information on that. The Intensive Care Society might need to. I think within that guidance, which of course is Intensive Care Society guidance, it's not NHS England guidance. So in a sense, it's come from a professional society rather than a government agency. I think the emphasis was an awful lot more on the principles of managing patients and escalation in a pandemic, rather than necessarily simply the use of a tool.
Do you consider that at times when ICUs were under pressure and anticipating an imminent surge in demand, so that not all their beds are necessarily full yet, but is it possible that a sort of preemptive rationing could come into play? So decisions being made about which patients to admit to intensive care to avoid the situation where all the beds are already full and then the peak of the wave hits?
Yeah, that would be the wrong way around in my view, because the CRITCON system and the principles behind it are that clinicians should continue to make the usual judgments that they make. And of course, those judgments flex according to the circumstance. I know that from my time as a clinician. But in essence, the object is to ensure that clinicians continue to make the usual decisions that they would make outside of a pandemic until the point at which you are at CRITCON 4, which fortunately we never reached as a system.
Thank you. Can we move on, please? You mentioned briefly DNA CPRs.
Yes.
And I wonder if we might move to that topic now, and the role of NHS England in publishing guidance around DNA CPRs during the pandemic. I think you've set out in your third witness statement that prior to the pandemic, as a result of the 2019 Learning Disability Mortality Review, which found that in some of the cases, the DNA CPR notices that they reviewed, which would have been put in place in 2018, learning disabilities had frequently been cited as a reason for a DNA CPR notice being placed on a patient's files. And as a response to those findings, NHS England in 2019 issued communications to the system to make it clear that DNA CPRs applied generically to patients with long-term conditions such as learning disabilities are entirely inappropriate. Is that correct?
That's absolutely correct. I wouldn't necessarily say it was frequently. I'd need to look at the detail of the report, but there were sufficient numbers for us to become concerned, and therefore necessitate writing to remind people that this was completely inappropriate.
And that might sometimes be referred to as a blanket DNA CPR decision, so a decision made on an inappropriate basis. And the inquiry has heard evidence of a number of concerns, particularly of our some of the core participants to this module, that blanket DNA CPR decisions were being made in healthcare settings. Were any concerns of that nature brought to the attention of NHS England during the pandemic. I'm talking about outside of media reports, but specific instances.
Yes, we heard this through a variety of sources that I think I've outlined in the statement at the end of March and early April, and we took immediate action. We wrote out and communicated on a number of occasions during the pandemic to state that the use of blanket DNA CPRs is completely inappropriate.
You mentioned earlier that the NICE guidance. If we can get up, please, the letter that you issued on the 3rd of April, which makes some reference to the NICE guidance. It's INQ 000216 So explain there that you're writing to colleagues to ensure that there's clarity in relation to the use of the clinical frailty scale and the use of DNA CPR with younger patients with a stable long-term physical need, learning disability or autism. And there's reference to your letter of May 2019, which we've already heard about, that learning disability and Down syndrome should never be a reason for issuing a DNA CPR order or be used to describe the underlying or only cause of death. Learning disabilities are not fatal conditions. And there's then a reference to the NICE rapid guidance on admission to hospital and critical care. And the guidance made reference to assessments using the clinical frailty scale. The guidelines were amended on the 25th of March to make clear that the clinical frailty scale should not be used in younger people and those with long-term disabilities, learning disability or autism. So were there concerns at that point that the guideline before it had been amended may have misled clinicians to assume that the clinical frailty scale might also be applicable to younger people when making DNA CPR decisions? Was that the
So clearly that was the risk that we wished to address with this letter. I think this was a letter written by my colleagues referencing my original letter, which, to be clear, the original 2019 letter was in response to both learning disabilities being used as a reason for DNA CPR orders, but also being placed on death certificates as a primary cause of death, both of which are not acceptable. But yes, that was the risk we were addressing, that guidance might be used inappropriately. And of course, going back to our early discussions, I think, and again, this was NICE guidance, so I don't know the detail, but I suspect that if there had been a longer time to produce this guidance and more the ability to have more consultation and more scrutiny, this would have been picked up. So again, it's back to that, the benefits of rapid guidance, but also there are some disbenefits and some risks in producing rapid guidance.
Can I ask you briefly, after this letter was sent on the 3rd of April, I think you wrote again on the 7th of April in relation to blanket DNA CPRs being inappropriate on the basis of simply a medical condition, a disability or age. After those two letters had been sent out on the 3rd and the 7th of April, did NHS England at that point undertake any sort of follow-up to establish whether that guidance was being appropriately implemented?
Not that I recall at the time. You will know that the CQC were commissioned to undertake a report on this, and I don't believe that this was in widespread use, but there were enough anecdotes and information coming to us through a variety of channels that we felt it was important to address. And we did so, again, on a number of occasions, to emphasise that this approach was inappropriate. And also, if we heard that there was anecdotal information. But I think this was an issue mainly at the very start of Wave 1, around March and April. As I say, I don't believe it was widespread. I think the CQC report reflected that, but clearly we had heard enough examples for it to be concerning.
My lady, I don't know if that might be an appropriate.
Yes, certainly. I think you were warned not only that you'll be the whole of this afternoon, but have to come back on Monday. I hope that's going to be all right for you.
I think it will be fine.
I'm really grateful. Very well. I shall return at 10 to 2.
Thank you.
All right.